In this video, we'll discuss about atherosclerosis. Atherosclerosis. Previous video we have seen arteriosclerosis. Now we'll see about atherosclerosis. So, what is atherosclerosis? The definition: atherosclerosis, as the name suggests, it is deposition of atheromatous plaque in the vessel wall. So, it is deposition of atheromatous plaque position of atheromatous plaque in vessel wall. This is atherosclerosis. Now in which we'll discuss how this thermometers plaque look like and what are the risk factors. First we'll see what are the risk factors of this atherosclerosis. Risk factor we are divided into two categories. There are non-modifiable risk factor and the risk factor which we can modify by our lifestyle or habit. Non-modifiable, these are genetic or either genetic inherited or either inbuilt in the metabolism of the person, which we cannot change our daily routine habits. So what are the non-modifiable risk factors? The family history. Family history we cannot change. Family history is genetically that we inherit. Family history. Age, it is more common in the old age, because in old age there is a stiffening and hardening of the artery because of calcification, and more arteriosclerosis, which is also a risk factor for atherosclerosis. Family history, age, and it is more common in the male gender. Male gender it is more common. And also the presence of plasminogen activator inhibitor. So what is this plasmin? Plasmin is, we know that fibrinolytic. So it is plasminogen activator. The plasminogen is activated into plasmin, which causes fibrinolysis, which reduces the risk factor for deposition of atheromatous plaque or fibrosis. But this is plasminogen activator inhibitor, means this is inhibiting plasminogen. So plasminogen will not be activated into plasmin, so there is no fibrinolytic activity and deposition of fibrin plaques, which thus becomes risk factor of atherosclerosis. So increased serum level of plasminogen activator inhibitor is non-modifiable risk factor of atherosclerosis. It is genetically in few percentage of the population. There is it's noted that they have high level of plasminogen activator inhibitor in their serum. What are the modifiable risk factors that we can modify by habit? This is smoking, alcoholic. They are higher risk. Those who smoke and drink alcohol, and those people who are obese, or those people who have higher LDL level, low density lipid, which is bad lipid, and low level of good lipid, HDL, or we can say hyperlipidemia. Hyperlipidemia, those patients, or those patients which have higher cholesterol level, hypercholesterolemia, hypercholesterolemia, or those who have hypertension are more prone, or those who have diabetes mellitus are more prone, and also those people which have higher level of homocysteine, higher level of homocysteine in their blood. So hyperhomocysteinemia is a risk factor for atherosclerosis. You have to read that high level of homocysteine is a risk factor for heart and vascular diseases. So hyperhomocysteinemia is a risk factor. So smoking, those who smoke, alcohol, those who are obese, high level of lipid, high level of cholesterol, hypertension, diabetes mellitus, hyperhomocysteinemia, and also those who have inflammatory conditions, or have an inflammatory condition, inflammatory bowel disease, inflammatory heart disease. Yes, so what is the marker of this inflammation? Those person who is having inflammation have higher level of C-reactive protein, CRP. C-reactive protein is higher in their blood. So C-reactive protein is directly proportional with the increased risk of the heart disease. So higher the level of the C-reactive protein, higher the person is prone to developing the heart disease or is having heart disease. So either inflammation or disturbances in hemostatic disturbances can also be a modifiable risk factor. Hemostatic disturbances we'll see that hemostatic disturbances will lead to hemodynamic disturbances that leads to Krepel-like factor 2, which we'll see KLF2 Krepel-like factor 2. So it causes increased production of atherosclerotic gene transcript and decrease in inflammatory gene transcript, leads to atherosclerosis. We see this further. What is this hemostatic disturbances? So these are the risk factor for atherosclerosis. Now see about what is the structure of this atheromatous plaque. How this atheromatous plaque look like. The chronological order, we should first see the pathogenesis, but here now we will first see that how this plaque looks like. So this plaque has a fibrous cap. First structure, it has a fibrous cap of the plaque. That's the most. If we look from above side, the first structure we'll see is fibrous cap. Fibrous cap composed of smooth muscle, extracellular matrix. Extracellular matrix means glycoprotein, proteoglycans, nectins, composed of that smooth muscle, extracellular matrix, and it also composed of muscle fibers. So this called the fibrous cap, smooth muscle, extracellular matrix, muscle fibers, and muscle fibers is what kind of fiber that can be collagenous fiber or non-collagenous. Mainly collagenous, can also include non-collagenous fibrous cap. And now there is other part from the shoulder of the atheromatous. It composed of, it also contains smooth muscle. Smooth muscle is the common part. Smooth muscle, and yeah, it also contains macrophage and T lymphocyte. So smooth muscle, macrophage, and T lymphocyte, they constitute the shoulder part. Then there is a necrotic core. Necrotic core. So as the name suggests, necrotic core, it will surely have necrosis, or we have dead cells, and we also have foam cells. What are these foam cells? Foam cells are these lipid-laden macrophage. These are foam cells, and we also see cholesterol crystals, cholesterol claps in the necrotic core. We'll see like that. With cholesterol crystals, we'll see cholesterol clap-like features of cholesterol. So fibrous cap, your shoulder, necrotic core, and what to see in the periphery. The periphery will see neovascularization around the necrotic core. So new blood vessel formation, neoangiogenesis, neovascularization around the atheromatous plaque. Atheromatous plaque constitute of fibrous cap, shoulder, necrotic core, and periphery. Uh, Fibrous cap composed of extracellular matrix, fiber. It is fibrous cap means there should be fiber. So what kind of fiber? The collagenous fibers. And we have smooth muscles and extracellular matrix composed of glycoprotein, proteoglycan, nectins, and all other protein. And shoulder part consists of it also contains some smooth muscle, mainly macrophage and T lymphocyte. Necrotic core, this name suggests this will be area of necrosis, or all over we will see dead cells. And we also see foam cells. Foam cells are lipid-laden macrophage. We also see cholesterol claps and cholesterol crystals in the form of claps. And in periphery, we see neovascularization or neoangiogenesis, the formation of new blood vessel. This was about this atheromatous plaque, this morphology, this plaque. You can see the diagram in your textbook that how it looks like. So to sum up, we have fibrous cap, shoulder, necrotic core, and in the periphery we are having neovascularization around the atheromatous plaque. What is this fatty streak? Fatty streak is a yellow plaque. The earliest lesion of the atheromatous plaque earliest lesion of the erythematous plaque is called fatty streak. So yeah, fatty streak is like a macule. If you see, it is a yellow flattened macule. It is not rest. And fatty streak, as name suggests, fat is composed of the foam cells. So before formation of erythematous plaque, there is a formation of yellow flat macule, which is called as fatty streak. It is the earliest lesion in the erythematous plaque. In the blood vessel, first we will see a yellow flat macule, flattened macule, not raised, not raised and erythematous. It is yellow and flat, and this macule, and it composed of foam cells. We are seeing here foam cells and the earliest lesion. This lesion then transformed into that well developed adult uh, erythematous plaque consists of fibrous cap and shoulder, necrotic core, and periphery neovascularization. So this this is the chronology that I have to know, that there is fatty streak. You should just know this chronology. Fatty streak, earliest lesion, it will develop into erythematous plaque. Fatty streak leads to erythematous plaque. They just ask you what is it? It is flat or raised? It is flat. It is yellow or red or erythematous. It is yellow. It is maculated appearance. It's the earliest lesion. It can lead to formation of erythematous plaque. It is a previous. So erythematous plaque is the next congener of this fatty streak. You can say. So about fatty streak. So this was the plaque as formed, but we have to ask that how is this plaque was formed? That what is the pathogenesis? That how we have seen that what is this plaque, but we have not seen that how this plaque is formed. So we have seen the risk factor. We have seen various risk factors like modifiable and non-modifiable risk factor, age, gender, male gender, especially plasminogen activator inhibitor, which are non-modifiable risk factor, and high level of lipid, hypertension, hyperlipidemia, hyperhomocystinemia. Those were all smoking, alcohol, obesity. Those were all non-modifiable risk factors. So there is a hypothesis called as a response to injury hypothesis. The erythematous plaque develops in response to an injury. So what is the hypothesis? There is response to injury hypothesis. So what is this response to injury hypothesis means? It says that erythematous plaque develops in response to an injury. In response to which injury? So the injury to the endothelium. So it says that injury to the endothelium. So how the endothelium is going to be injured? Endothelium will be injured by inflammation, by hyperlipidemia, hyperhomocystinemia, or hemodynamic disturbances. All that will lead to injury to the endothelium. So all this risk factor, inflammation, hyperlipidemia, hyperhomocystinemia, hemodynamic disturbances, all that leads to injury to the endothelium. So if this risk factor causes injury to the endothelium, what will happen? Increase in the permeability. There is increase in vascular permeability, increase in the permeability to the endothelium. So because of the increase in permeability to the endothelium, there in the blood there are working leukocytes and monocytes. They will go and they will come and adhere to the endothelium because of the endothelium is injured. So leukocyte is L and M cells. What is L? L is leukocyte. M is special monocyte, especially the monocyte from the leukocyte. They'll come and adhere to the endothelium. So leukocyte and monocyte adhesion. After the leukocyte and monocyte adhesion, we'll see. So what is this response to injury hypothesis? Response to injury hypothesis is that there is endothelial injury. Endothelial injury due to all the risk factors we have already discussed. It leads to increase in vascular permeability. Vascular permeability in the blood vessel, we have leukocyte and monocyte. They will come and adhere to the endothelium, leukocyte, monocyte. And also because of the hyperlipidemia and hypercholesterolemia, high level of LDL and its oxidized form will also come and adhere to the endothelium. This leads to the neointimal hyperplasia. What is this neointimal hyperplasia? Neointimal hyperplasia. What is this neointimal hyperplasia? There is smooth muscle migration from tunica media to tunica intima. So what is this neointimal hyperplasia? There is smooth muscle migration, the migration of the smooth muscle from tunica media to tunica intima. Tunica intima is the innermost layer. So smooth muscle migration from tunica media to tunica intima, and also there is hyperplasia of the smooth muscle. Hyperplasia or hyperproliferation of the smooth muscle in the tunica intima, innermost layer, which lead to occlusion of the lumen of the blood vessel. So this neointimal hyperplasia is a phenomena in which the smooth muscle progenitor cells, they migrate from tunica media to the tunica intima. So we all know that smooth muscle are present in the tunica media layer, but in the atherosclerosis condition, smooth muscle, there is migration of smooth muscle from instead of tunica media where there should be smooth muscle, there is migration of smooth muscle from tunica media to tunica intima, and migration, and then there are hyperproliferation of the smooth muscle leads to formation of atheromatous plaque which occlude the lumen of the blood vessel. So there is a accumulation of LDL in its oxidized form leads to neointimal hyperplasia, and that leads to first there will be RDS lesion, that yellow flat macule, and then at last there will be formation of a mature atheromatous plaque. So this was in short the pathogenesis of atherosclerosis. What is the hypothesis? What mechanism is response to injury hypothesis? All those risk factors which we have studied, hyperlipidemia, hyperhomocystinemia, hemodynamic disturbances, all this leads to endothelial injury. Endothelium is injured, so there is increase in permeability, increase in vascular permeability. There is addition of leukocyte and monocyte first, then addition of LDL low density lipid and its oxidized form. Then there is neointimal hyperplasia, the phenomena in which smooth muscle migrate from tunica media to intima and hyperproliferation of smooth muscle. And then there is leads of that earliest yellow flat macule, and that leads to formation of adult atheromatous plaque. Now we'll discuss about one thing that was left, that what was that hemodynamic disturbances. So hemodynamic disturbances. What are the hemodynamic disturbances? Hemodynamic disturbances, we know that two type of flow, the turbulent flow and there is a laminar flow. So laminar flow and there is a turbulent flow. Laminar flow means there is a patterned flow. So it is not a random flow, it is systematic, well patterned flow. A turbulent flow, it is just lines are crossing, it is not streamlined. Laminar flow, it is streamlined flow. Turbulent flow is just there is random flow. So there is this we have the laminar or the non-turbulent flow in our blood vessel. So the disturbances in that blood flow because of increased lipid and cholesterol in the blood, which will lead to increased density of the blood. So they disturb this our blood flow. Hemodynamics, they will disturb the regular laminar or the non-turbulent flow. So once that flow will disturb, there increase in production of the Gruppel-like factor 2. What is this? Gruppel-like factor. Gruppel-like factor 2. That leads to increase in inflammatory gene transcript. Increase production of inflammatory gene transcript and increase production of atheroprotective gene transcript. Atheroprotective gene transcript. So couple-like factor causes increased production of atheroprotective gene transcript. So there will be formation of atheromatous plaque. So this also has become risk factor. So all we have to know that hemodynamic disturbances lead to disturbance in the laminar or the non-turbulent flow. That laminar or the non-turbulent flow that leads to increase in the couple-like factor 2. What the couple-like factor 2 causes? It causes increased production of atheroprotective gene, increased production of inflammatory gene transcript. So these are all the risk factor for the production of, so all that will lead to endothelial injury. Endothelial injury leads to increased vascular permeability, and there is leukocyte monocyte adhesion of LDL and its oxidized form, neointimal hyperplasia, formation of atheromatous plaque. So this was about the pathogenesis of the atheromatous plaque, Also, we'll discuss what are the type of the plaque. So there is two type of plaque. There is a vulnerable plaque and another plaque is stable plaque. As the name suggests, this is vulnerable plaque. So it has which one is more dangerous? Obviously, vulnerable plaque is more dangerous because it can move from its origin site and move to a distant site, like in the brain. It can cause cerebral infarct. Stable plaque is stationary, so it is less dangerous. So it will not move to a distant site and cause myocardial infarct or cerebral infarct. Where this can cause, and it can transform from thrombus to embolism, and that can cause cerebral infarct or myocardial infarct. So it is more chances of that. More chances of claudication is with vulnerable plaque. So why it is more vulnerable plaque? Because it is higher lipid content. It is high. So lipid content is higher, means lipid are present in the necrotic core. So it is necrotic core content will be high. Here that we can say lipid content is low as compared to this. So necrotic core part, that also will be low. And you should tell which one will have thick fibrous cap. It is more vulnerable. It is more dangerous. So it should have thin fibrous cap. Should have thin fibrous cap. The number of fibers should be less and number of lipids should be more. That's how the plaque become dangerous. The fibers will be less. It can easily move the blood vessel. It will not adhere to that, and it can easily rupture. If there is thin fibrous cap, the plaque can easily rupture and uh, move to distant site. Here there is thick fibrous cap. You should tell where the fiber content will be high. Vulnerable plaque, the fiber content will be low, less collagen fiber. Here will be the more collagen fiber. And you should tell also about density of the collagen. Here the type of the collagen that will have less dense collagen. Less dense collagen. Here you will have more dense collagen. More amount of collagen and more dense collagen. Because it is stable plaque, it is not motile as compared to that. So here higher lipid content, higher necrotic core, or you can, or if they are also called foam cells. So here foam cells contain, where foam cells are actually the lipid laden macrophage in the necrotic core. The foam cells will be higher, the fibrous cap will be thin, so that it can easily rupture and move to distant side. Less amount of collagen and less dense collagen. Here more collagen and less more crisscross arrangement of the collagen, and it is stable, and lipid content is less, fiber content is high, collagen fibrous content is very high. So it is stable plaque. Now we'll see what are the complication. What are the complication of this thermatus? Complication, it is first complication is aneurysm. This is a simple trick. Rather, I should tell that ACUT. First complication is aneurysm. Atheromatous plaque can lead to aneurysm of the blood vessel. Atheromatous plaque can also lead to calcification of the blood. Calcification of the blood vessel. No calcification of blood vessel, that can further lead to arteriosclerosis. What are the complication of arteriosclerosis? That was same: aneurysm, dissection, aneurysm of the plaque, aneurysm of the blood vessel, dissection of the blood vessel, cerebrovascular damage, hemorrhage, that's the complication of the arteriosclerosis. So aneurysm, calcification, the erythematous plaque can undergo ulceration, it can undergo thrombosis, it can undergo embolism. You know that which one have more risk of this thromboembolism is more with the vulnerable plaque. See, you can also have the plaques can also cause claudication. Claudication of the blood vessel that can be lead to impaired blood supply. Claudication, once the blood vessels are claudicated, that leads to impaired blood supply. That impaired blood supply can form infarct. It can form infarct. It form infarct in the brain. It will be called as cerebral infarct, and that cerebral infarct can further leads to cerebral hemorrhage or myocardial infarct. MI. We will call that myocardial cerebral infarct or myocardial infarct. Cerebral infarct can further lead to hemorrhage. These are the complications: aneurysm, calcification, ulceration, thrombosis, embolism, claudication leads to impaired blood supply, myocardial infarct, or cerebral. You see that in the complication, this one thing that is not there. It's not dissection, not aortic dissection or blood vessel dissection is not the complication. You should know that the dissection was the complication of arteriosclerosis, not the atherosclerosis. Dissection is a complication of arteriosclerosis. Atherosclerosis does not causes dissection, though it indirectly it can cause, but it is not the direct complication because it's causing calcification. The calcification can lead to arteriosclerosis, and arteriosclerosis is complication of dissection of the blood vessel. So it's an indirect complication. So we'll not write that. This was all about atherosclerosis in short, and also they can also ask you one thing was left. It was the most common blood vessel affected by atherosclerosis. So abdominal aorta. Abdominal aorta is most common affected by atherosclerosis. That's why we see aortic dissection, aortic aneurysm, calcification most commonly in the abdominal aorta. So abdominal aorta is the most common blood vessel affected, followed by coronary artery in the brain can also affect it. Coronary artery to cerebral infarct, popliteal artery, and internal carotid artery. The internal carotid artery. And least common affected is circle of Willis. What is the trick to write that? The CPI. Coronary artery, popliteal artery, internal carotid artery less than in the circle of Willis. So coronary artery, popliteal artery, and internal carotid artery. This is the order. And least commonly affected is the circle of Willis. Most commonly affected is the abdominal aorta. Is the most commonly affected. So these are the blood vessels most prone to the formation of athermatous plaque. Either get athermatous plaque in abdominal aorta, so it lead to complication of the blood supply in the organs of the abdomen or the abdominal organs, or the coronary artery in the heart, and popliteal artery, internal carotid artery in the brain, circle of Willis. So it is coronary artery, not carotid artery. It is coronary artery, coronal blood vasculature in the heart, not in the brain. I've said wrong. Popliteal artery, internal carotid artery, and circle of Willis. This was the blood vessels that are more prone to the formation of athermatous plaque. They will ask you the most common blood vessel that can lead to aneurysm. So it will be abdominal aorta, aneurysm, calcification, claudication, ulceration, thrombosis, embolism. All that most prone is abdominal aorta. So all about atherosclerosis. Thanks.